Welcome everyone. This is Dr. Fisher of United Psychological Services. Good afternoon and good morning, and thank you for joining us today. Before we get started, please remember that this is a listen-only call, which means that I am unable to hear you. If you have any questions as we move along in our call, please reference the box that you should have on the right side of your screen. That would have popped up when you logged in. That box will allow you to send questions over to me instantly, and if I am able to incorporate those into my talk at that moment, I will do so. However, please know that I will address any and all questions at the end of today's call. If there's something that you would like to speak to me further about, I will be available immediately following today's webinar, so feel free to call my office at 586-323-3620. Again, that number is 586-323-3620. All right, so today's seminar is separating out the different types of dementia and what we can do about it. We're going to be talking about Alzheimer's, cardiovascular, frontotemporal dementia, and Lewy body, because those are the four most common types of dementia that you would find in your practice. The objectives of today's webinar is to define the cognitive symptoms that are seen on neuropsychological testing and evaluation, understand the emotional changes that go along with those cognitive changes that are associated with dementia, and determining the effect of dementia upon the aging process and exactly what it looks like from a clinical perspective that I have seen for 24 years. And then the treatment that we've been using for almost 10 years, which is a brain training program that we've had excellent results. So this is the age of neuroscience, when diagnosis is on the cutting edge and any disorder can be treated. And what's so exciting about that is that we can actually do testing for dementia and see the beginnings of dementia long before it's seen in the person's daily life. What's so significant about that is twofold. One, everyone knows, and it's very well known, that the treatment in terms of medication for dementia is always best when you get it right at the beginning, when it's in its mild form. And the treatment for dementia shows the least progress the more severe that it is. Secondly, our brain training program has been having a wonderful effect. And so what it comes down to is that we can diagnose early, and we can actually prevent the full-blown syndrome of dementia, particularly the Alzheimer's dementia, because the other dementias, cardiovascular, Lewy body, and frontotemporal, have physical basis to them. But the Alzheimer's dementia, which is by far the most common dementia, we can literally diagnose, treat, and prevent full-blown symptoms from happening. That's what we have been seeing in our clinical experience, as long as you diagnose early. So what's important is that anyone who has an aged person in their life, or that you're seeing in your practice, is to pay attention to those early signs that there might be dementia occurring, because that is when you can have the most impact, and it's truly amazing the impact you can have. So what are some of those early signs? That's what we're going to talk about right now. Memory. We all know memory is the biggest and the best sign that something's going on with the brain. So when there's memory problems that occur, when somebody's doing daily tasks or appointments or anything, that they start to have a memory problem, even a conversation that they've forgotten that took place the day before. Now, obviously, if the person's under a lot of stress, you're going to take that into consideration. But when you see memory problems happening with an aged person over and over in different ways, don't wait too long before you get testing done. The second biggest issue is getting lost in familiar places, having a route-finding problem. And that is what we find a lot. We find a route-finding problem right at the beginning. It's not just getting lost in the grocery store. It's getting lost on a familiar route that they've taken often, and then all of a sudden they can't find it. So it's very important to track that. In fact, that's the way that I started testing my mother, who has not yet been diagnosed with Alzheimer's, but she has had some mild cognitive decline. But it happened when we were actually in New York, and she went to purchase the tickets, and then that evening couldn't find where she had to purchase the tickets from after she had already walked there. Long story short, it's when someone has already been somewhere and then they can't find it, and they have that disorientation to them. That is your wake-up call that you want to start to do some testing. Now, in the case of my mother, she has not proceeded with her physician to get on the medication because we're still tracking her from year to year, and the decline has not shown that it's that severe that she needs that, because she's in the really, really, really mild stages. But my point is that you want to be able to diagnose early and track it, and then, of course, make the decision of medication or not medication with the physician. But again, the earlier we get things, the better the outcome. So what are some other things? Of course, unable to make decisions. Now, these are things that you're going to see as time goes on. So as the dementia gets more severe, then you'll just see the decision-making process. Then you'll see the emotions where they become paranoid and they accuse people of things that aren't true, when the conversations don't make sense. Old personality emerges. When these latter symptoms occur, the person is already in a later stage of decline. So the early signs are really going to be memory and getting lost. And again, at that point, then you have the option, as the case of my mother, of tracking it, making a decision with the physician of whether you're going to treat that with medication. In my mother's case, we did the brain training program, which has been working very well. So where does neuropsychological assessment come in? Well, the neuropsychologist is the arm of the neurologist. They're the helper for the physician to track the changes in the brain that aren't going to be seen on radiological findings like the MRI or the functional MRI, or changes that might be seen on the SPECT scan. Those take time. This is before those changes are seen. That's when neuropsychological evaluation can be so significant. And so it's the use of paper and pencil tests. They're actually a lot of fun with the individual until they have some of the memory tests. Those aren't quite as fun. And they measure the different areas of the brain: frontal, temporal, or memory, parietal, sensory, or visual, spatial. And so again, the importance of neuropsychological assessment is that you can track the changes over time, and then you can decide what type of intervention that you want to make with the person who's close to you or your patient. Memory loss can be the primary symptoms in the following cases. Of course, in sleep apnea, Alzheimer's, cardiovascular, you can see all this on your screen. The main issue with that is that when there's memory loss, that's the time that you then want to take a look at what else is going on and for the reason as a causal factor for that memory loss. In other words, if you have someone who has a cardiovascular history, and then they're giving you symptoms of sleep apnea, they're waking up in the middle of the night and they can't breathe, or their significant other is hearing them snore and the snoring is getting louder and louder, and we've already assessed them and found memory loss, that's when that you would want to refer them as the physician to the sleep study, have a sleep study done and track sleep apnea. So the point is that you can use the type of memory loss and the pattern in the test results to then make decisions as to what other kind of treatment or testing that they need, not just in determining what type of dementia they have. So what are some memory questions? These are just basic memory questions, and you have all of this in front of you. But it's the point of, these are things that you can ask your patients or someone close to you if they have these problems. And that is, they have difficulty remembering things, and you see all the questions listed on your screen. And so this is just a good rule of thumb to ask individuals to track if they are developing dementia. And then the next page is a continuation of those different memory questions. And again, these are different questions that you can ask the patient to see if they are beginning to have memory problems for the purposes of diagnosing early. So what are the primary types of dementia? Well, of course, the mild cognitive decline, the Alzheimer's, cardiovascular, the Lewy body, which we know is the precursor for Parkinson's. And then, of course, there's a lot more research coming out recently on the frontal temporal dementias, the true dementias where the tau protein is involved. And then we also know through recent research that's very clear is that anyone who has had a brain injury, especially if it's later in life, or if they've been compromised through life by epilepsy or a frontal lobe disorder, is at risk for dementia and less than graceful aging. Mild cognitive decline. Recent research clearly shows it's a precursor of another form of dementia, of Alzheimer's. The way that it's detected early are a number of different studies. The MRI, PET scans, they're looking at the gene, the cerebral spinal fluid, etc. Of course, we know there's an increased risk with age, obesity, dietary fat, diabetes, and as I indicated, traumatic brain injury. The new research is also showing that there's an increase when there's insomnia because they're tracking changes in the cytokines. And so they're now relating longstanding insomnia as a risk factor for Alzheimer's. Elevated homocysteine, and then sleep fragmentation, decreased REM. So let's say you have a patient who has sleep apnea, and as a result of the sleep apnea, their sleep is fragmented, they have decreased REM, then they're going to be more at risk for Alzheimer's. The REM sleep behavior disorder, which is a sleep disorder where the person loses the atonia that they normally have in REM and act out their dreams, is emerging as a marker for less than graceful aging and for Alzheimer's as well. And then there are some other additional statistics, which is individuals who are married longer and then lose their spouse because of the depression. Also, of course, we know that there's an increased risk due to stress, and that would be for individuals who have a lot of children and live in a community that's not user-friendly, and of course, emotional trauma. So what do we know about Alzheimer's? Well, Alzheimer's dementia is doubling every 5 years over the age of 65 years. But if you think about it, Alzheimer's dementia is really emerging as a bin, very similar to ADD or even the autism spectrum at this point, where we're putting all kinds of Alzheimer's types. And one of the issues that the neurology community is indicating is that it's very important to separate out the types of dementia, especially when the frontotemporal dementia is involved, because the treatment's different. And of course, the progress or the path of the decline is different as well. So I think that we see a lot more Alzheimer's because, of course, people are living longer and there's other factors as well, and our own health and how we're taking care of it. But on top of that, that Alzheimer's dementia is really emerging as a bin that we're dropping a lot of different diagnoses into that we need to separate out. Just a few important statistics. You can also see them on your screen. Is at the age of 60, the incident rate, of course, is 1%, and it rises to over 40% by the age of 85 years. So we also, again, as I indicated, it's affected by stress, post-traumatic stress disorder, insulin resistance syndrome, diabetes, etc. So there's all these different markers that we're now learning that lead to less than graceful aging, and less than graceful aging has been equated with, of course, Alzheimer's dementia. What's also important is to recognize that 70% of those diagnosed for 2 years do show mood change, apathy, depression, and social withdrawal. What's important about that is that they're citing that 70% of those diagnosed for 2 years are now moving into moderate dementia. That means that when they initially diagnosed the dementia, it really wasn't mild. It was probably moving more towards moderate dementia at that time, which again cites the point that I was making earlier about if we're tracking memory changes and root finding problems, we really could hit the true mild dementia a lot earlier than we are, and then make a huge difference for the individual. And again, just to reiterate, of course, Alzheimer's dementia is associated with Down syndrome. That was research that came out a while ago. Traumatic brain injury, diabetes. Females, there's a ratio of 1 male to 8 females. Lower education, post-traumatic stress disorder, depression, and then also fragile persona. So the idea is really beginning to be seen that if there's a fragile brain, there's a fragile immune system, you're of course going to be more at risk for Alzheimer's dementia. But what are the typical problems that we tend to see as neuropsychologists, or that we see at our clinic here? And that is, again, the memory loss for Alzheimer's is immediate and severe. But here's what happens with the memory loss with Alzheimer's. If you give them numbers, they can repeat them back. But if you ask them 5 minutes later what were the numbers, they won't be able to tell you. So what's important to understand about this memory loss, which I think sometimes people are missing, and as a result, then, of course, they're not diagnosing Alzheimer's until later, when they could have diagnosed it earlier, is the fact that people think that memory should be totally flattened, gone, done. And that's really not the case. What it happens is that with Alzheimer's, they lose their ability to register the newly learned information, to be able to pull it back out or retrieve it over time. So they can do short-term memory where they simply repeat back what you said, but they can't hold on to it. So the issue is holding on to the memory of information. And then, again, part of the problem in using the mini-status mental exam is that the information you're asking to hold on to is really pretty sparse. You're asking to hold on to and remember 3 names or count backwards. These are overlearned things that they're going to be able to do. And the piece about Alzheimer's is it's no new memories. It's not about old memories. It's about new memories. So if you really want to diagnose Alzheimer's and get the true mild cognitive decline before it gets more involved with the brain and is more severe, then what you're looking for is learning of new information and holding on to that information over time. You're not looking to see if they can recall information they've known all their life. And nor are you looking for them to repeat back what you just said. They can do that. So that's very, very critical. So the memory loss in that respect, as I just described, is immediate and severe because they can't form any new memories. That's where the problem comes in. And they also, you'll see issues that they can't find things, they don't recall conversations. And again, as I indicated, the memory of the past remains intact. So again, the biggest issue is a root finding problem. They can't retrace their steps. And it's not just in the grocery store. It's going somewhere where they've already been. Or they just went there and they can't get back there again. Those are the things. And you're looking for where the memory problem declines over time. Then you're going to see where they may forget faces. But that's going to be more in the moderate dementia. Procedural learning, learning new tasks, not tasks that they've already learned. Because again, you have to retain information to learn how to do a new task with a procedure. You have to retain information to do a new task with a procedure. So the key here is retention of new information. And that's what happens with word retrieval. It's not that they don't have the vocabulary, it's that they can't remember the words and keep it in a working memory process to then use when they need it. So that's why you see word retrieval associated with Alzheimer's. So how do we separate cardiovascular? Well, let's take word retrieval as an example. Word retrieval is highly associated with cardiovascular dementia because you're now involving the frontal area of the brain, and they have a true word retrieval problem where they lose, while they're searching for their word, they lose their thought and they can't remember what they wanted to say. So with Alzheimer's, it's a memory issue that they're having problems finding their words. But with cardiovascular dementia, it's a true word retrieval problem, word fluency problem, where they are forgetting what they wanted to say because they're searching for a word and then they lose the whole sentence due to attentional processes involving the frontal area of the brain. And so it becomes a different picture than you would typically see with Alzheimer's. On that point, when you do testing with cardiovascular dementia, you will see a different picture that involves both the frontal and temporal area of the brain, and it will present, again, differently in the initial mild cognitive decline from what you would expect with Alzheimer's that we've come to see over the years. What's important about cardiovascular dementia is that there's depression associated. You have to separate out what the impact is about the depression associated with cardiovascular, how much depression is due to the medication that they're on, and separate all of these issues. That's why neuropsych testing is so critical, because generally speaking, the depression does not necessarily affect memory testing. It may affect psychomotor tests, where you have to speed it up and go fast, but not testing where memory is involved. So you can really kind of separate out these components. And again, to be aware of the silent events, the TIAs. We all know that you have a number of TIAs before you have the big stroke. There's been a process going on for years before you truly see some results from this. So again, that's where neuropsychological evaluation is so important in pinpointing those things that people wouldn't know to have the cardiologist then follow up and look for. And that's where the neuropsychologist is so helpful to the medical profession. And we all work together. Common risk factors, again, as you all know, age, diabetes, family history. The big one also is sleep apnea or upper airway resistance syndrome, a narrow airway. It's very commonly known that obstructive sleep apnea or sleep apnea presents risk to the heart in a number of different ways, whether it be from not allowing the heart to rest and going from tachycardia to bradycardia, depending upon the breathing, to changes in the biochemical process, to actually injuring the left side of the heart. So again, sleep apnea is very well associated with increasing cardiovascular disease. And then again, you're all familiar with the common risk factors of smoking, poor diet, high blood pressure, etc. We already talked about sleep apnea. and alcohol abuse. We all know about the 1 drink per day, but once you get to 3 or 4 drinks per, 3 or more drinks per day for 3 or 4 days per week, then you're going to be risking the brain. So what are some symptoms that we see at our clinic as neuropsychologists for cardiovascular dementia? We see the memory problems, but the key issue in separating out cardiovascular from a neuropsychological perspective from Alzheimer's is that you see frontal deficits. And those are very specific deficits where they have a selective attention problem. That means they focus on everything. Everything's coming in. So they attend to everything, and therefore they can't attend to anything. And they tend to have a difficult time with a lot of stimuli, and by the same token, they focus on the irrelevant. And so they'll come up with something, and you'll think, well, where did you ever get that from? Because a lot of times they'll hear something, and they'll tie it to something that they're thinking, and they'll think you said it or someone else said it. And as a result, their thinking becomes skewed in that perspective. There is not a lot of cognitive flexibility. They're very rigid. Problem-solving skills are poor. They repeat themselves. They get stuck. It's like they'll present a statement, and you'll have a discussion about it, and they'll say, oh, yeah, you're right. And then you'll go back in, and they'll make the same statement again. And you'll say, well, we just had a whole conversation about this. And they'll come in and make the same statement because they're stuck on whatever particular principle or statement that they're making. Problems with sequencing, planning, organizing, and then there's a lot of emotional reactivity, a lot of impulsivity, and a decline in the ability to judge. Because again, the frontal area of the brain is the area of the brain that's responsible for inhibiting actions, for not being impulsive. And so as a result, when that breaks down, individuals become very impulsive, and that's also where they can go back to old personality and old patterns, because when the frontal area of the brain is not being a blockade for that, then what they think goes, what they feel like they do, and it goes on from there. You'll see symptoms of social withdrawal, depression, and then again extreme behaviors, as I indicated, a loss of inhibitions, inappropriate sexual behavior. We can tell you all kinds of stories that have happened when that area of the brain starts to break down. What's also important is that when you think about cardiovascular dementia, and it's going to be the same for the frontotemporal dementia, it hits the frontal temporal area of the brain. If it hits the right side of the brain, they lose a sense of self, of who they are, what they stand for, what were their values. That's where those things come in. The best case in point that I have is someone who had an aneurysm, this woman, many, many years ago, and she had an aneurysm in the right side of her brain. It took a lot of tissue from the right side of her brain. And after the testing, I said to her, is there anything that you're concerned about or any questions that you have? And her comment back to me was, I don't have any concerns and I'm fine. Now, she said, I'm fine, but understand that this woman had left her husband of 30 years. She had left her 2 girls who, one was pregnant and one had just had a small child, and ran off with a lover that she met over the internet, and she had apparently known him from high school and left from Michigan for Texas. So, point being is she didn't see that she had a problem. She was fine, but of course her whole behavior had changed. So again, that's the point of them losing a sense of self, their values, who they are, and then they can't get that back again. That's a very important issue. So what are the primary signs of Lewy body? The biggest thing that you're going to see with Lewy body that we see at our clinic is that they become psychologically problematic. They develop psychosis very, very quickly, very early in the stages of dementia. And as a result, they become highly suspicious and paranoid and confused in their thinking, with tangential thinking and emotionally labile mood swings. Their emotions go up and down with no rhyme or reason. They don't make any sense. And that emotional psychosis is very clear, very frank, and it happens very early. So that's the important thing. You're talking about the frontal area of the brain that gets hit very hard with the symptoms I just described, along with the parietal or the spatial processes. So if you ask them to draw things that you would expect them to know, then they would have problems doing that. And again, it's just a wake-up call that's been associated as a precursor to Parkinson's disease or associated with Parkinson's disease. So again, the emotional is the big impact, and when you see that in someone, you want you want to really think about if you've got other symptoms that would suggest Lewy body, especially if you're getting some Parkinsonian symptoms as well, and you very well may be looking at Lewy body dementia. So it's very important to separate that out, and also because their symptoms are going to be very profound when that occurs. The cognitive symptoms, again, as I indicated, are drawing and copying of designs, but the biggest issue is really going to be problem solving, misperceiving, and that frontal area of the brain gets hit very hard, very quickly. And that frontal area of the brain is what we all rely upon to adaptively function every day in our environment. Frontotemporal dementia is something that we're going to start hearing a lot about, and this is the dementia that involves the tau protein marker. There are four major issues involving frontotemporal dementia, FTD, and that has to do with the social interpersonal, the personal conduct, emotional blunting, and loss of insight. It's all hitting the frontal area of the brain. So all the symptoms involving the frontal area of the brain, such as problem solving and judgment and control of emotions and control of the decision-making processes and cognitive thinking flexibility, those are all issues that are going to be seen rather quickly. And the problem is that a lot of times the symptoms may be misread for frontotemporal dementia as Alzheimer's. And the Alzheimer's medication will not work with frontotemporal dementia at all. And then time will be lost when this is a more aggressive dementia. It's more aggressive dementia that hits very severe points rather quickly. So it's very important to separate that out from Alzheimer's, which the neuropsychology field can do rather quickly with testing before the medical world may be able to separate out some of those symptoms unless they get a very good historian in the group associated or coming with the patient. So again, depending on what hemisphere you're affecting is when you would see other issues in terms of language or visual memory or prosopagnosia, which is a dressing problem, or visual spatial problems. So what are the issues in comparing frontotemporal dementia versus Alzheimer's is, again, you would look at structural findings, but the biggest thing is that you would see frontal symptoms that would show up rather very quickly and very profound that you are not going to see with these Alzheimer's dementia in the early stages. So the early symptoms, the markers of dementia is going to be psychiatric because, again, you're involving the frontal area of the brain. As I indicated, you're making decisions, word retrieval, etc. They're going to be easily tired and affects their participation in life activities. So what are some just overall markers of cognitive decline? And again, to cite the research again, we know there's an increase of brain inflammatory, such as cytokines, C-reactive protein, homocysteine levels. When there's an increased influx of calcium, intracellular calcium, you have things breaking down inside the brain, increased oxidative stress, etc. These are all factors that have been cited in the research. And as I indicated, also the REM sleep behavior disorder, when the atonia is always present with REM sleep so that you can dream and not act out your dreams is broken and the person is acting out their dreams. That's emerging as a marker of cognitive decline. Wisdom is the reward you get for a lifetime of listening when you'd rather have been talking, and that's from Aristotle. So what are the true facts of graceful aging? Reading rate does not change during the aging process. Memory truly does not decline until the late 80s or 90s in the normal aging process. Everyone has the ability to age gracefully. We are living longer. Everyone has the ability to age gracefully if we practice preventative medicine and we are able to diagnose symptoms in the very, very beginning. There's so much that we can do these days so that no one has to go through the awful process of a dementia and decline. We truly have the power and the ability to make a difference in the way people age gracefully between the medical profession and the neuropsychological profession. Working together, we can truly make a difference. The connection of mind, body, and spirit. There is so much we can do today by finding out how the brain works, how sleep affects the brain, understanding how medication affects the brain, and what we can do to make things different early. And that's the value of neuropsychological assessment, working as the arm of the um, physicians, internists, cardiologists, and neurologists. So what can we do in our 40s and 50s to promote graceful aging? Keep yourself active. We all know that keeping your brain active is very important. People who age less gracefully have an impact of stress, and they want to identify problems early. And again, watch your sleep. I can't say enough about the problem of sleep apnea. These are my mother's aging tips, who at this day, because of brain training, actually is holding on. We're doing serial testing, and she has not started any treatment for dementia, and is doing very well. So these are her aging tips. She says, remain organized and don't give up. Exercise regularly. Join different groups. Don't sit home. Ride a bike. Go to movies. And don't believe anyone who says you're too old. Social groups, of course, reading books, and then also the computer is very important these days, as you all know, to communicate. So those are her tips for how she's still holding herself together. People who age less gracefully, recent research showed that Alzheimer's dementia increased 50% with each point that increased on a loneliness scale. So in other words, a scale that was filled out by people indicating how they were lonely. With each additional point, there was a 50% increase of dementia. So my mother's point about being involved in social groups actually is correct. Divorced men and women are more at risk, men and women without children, negative thinking individuals, men who have lost a spouse, people who are continually stressed, and people who lose their belief in wealth. And we all know the power of someone who dies, and it isn't very long before the spouse dies as well if they're very connected and very close and they don't find anything of interest in their life. So again, I can't say enough about stress. We know it's a factor in cardiovascular disease. We certainly know it contributes to insomnia. We know there's an increase in anxiety and depression, decreased attention and focus, which we have measured as neuropsychologists, and your energy as well. It's very important to identify problems early, and that's where the sundowner syndrome becomes a very, very important concept. The idea being that people decline as the sun goes down. So as you get more tired, you're not going to be able to compensate with other areas of cognitive reserve in your brain when there's a problem. So if there's a problem in one area of your brain, you're going to be less able to use other areas of your brain to compensate when, as neuropsychologists, testing is done, that because as the sun goes down, they get more tired. So the point is that what we do in our clinic is we will test individuals at different times of day for memory to track how that memory changes with time. It also tells us about their cognitive reserve and their ability to compensate. Again, you see more agitation and wandering and problems with behavior as the sun goes down. So don't assume that someone's fine if you only see them during the daytime hours. And again, little signs can become big issues. I can't tell you that enough. A big issue that starts as a little sign is really canceling social engagements. So if someone is continually canceling social engagements and you see that like 3 or 4 times and that's not part of their nature, then your ears really want to perk up and you want to think about having them evaluated for dementia. And again, evaluation for dementia doesn't mean them going on medication. It just means they're going to be evaluated for dementia. It may mean keeping a watch on them and doing serial testing, and it may mean the intervention of our brain training program. It may mean the intervention of some vitamins and different therapies, depending on what their physician says. But testing for dementia doesn't always mean that they're going to be treated with the medications being used for dementia, the anticholinergics. So what's the impact of poor sleep? Well, you've heard me say that a number of times. It's very important to get enough sleep and get good sleep. The new research that has come out is now saying that less than 6 hours of sleep actually results in alterations in the cytokine, an increase in obesity, insulin resistance syndrome, metabolic immune system, and vascular markers. They're also seeing that when there's poor sleep, an impact in terms of Alzheimer's and connecting the two. You want to make sure you rule out sleep disorders. A recent NIH study showed that 12 million people have sleep apnea. There's 2 problems with the sleep apnea issue. One, we're not diagnosing it. Mouth breathing and snoring is significant. When you snore, your airway has already narrowed. It's already happened. Secondly, the CPAP compliance, and I will be doing a webinar in the next week or so on CPAP compliance. Problem is that we have individuals come in, they do a sleep study, they're pronounced sleep apnea, a service shows up, plunks them on a machine, and nobody calls them back to see if they can use the machine. Nobody finds out if the machine's going to be comfortable for them. Nobody works with them from a behavioral perspective, which we do at our facility, to help them to be CPAP compliant. So here we are diagnosing all these people, but you'll find that approximately 50% actually even use the machine. So not only do we have a problem getting people to the sleep study for diagnosis, but then it's even cut in half once again because they're not even using the apparatus once they get it. So be aware of advanced phase sleep syndrome, which means the person wants to go to sleep at 6 o'clock, and then they wake up at 2 o'clock in the morning. Aging process, sleep changes. They have more arousals and reduced sleep efficiency. Again, the correlation because of insomnia with short sleep time, weight gain, and illness. And then I already talked about REM sleep behavior disorder. What are our treatment options? Well, understand that a cognitive decline occurs prior to adults having difficulty. So diagnose early. I cannot tell you that enough. A recent NIH study showed that in adults 65 years or older living independently who had cognitive training, and they just did a small amount of cognitive training, actually had less of a cognitive decline and showed improvement. So there's so much that we can do. Diagnose early, and we're treating with our brain training program. There is a program called Interactive Metronome that we use here. That's one of our brain training programs, and pre and post testing comparisons show an overall improved functioning, quality of life, improved functioning for depression and also anxiety. And we're also seeing emotional changes, as I mentioned again, of depression, but an improved sense of well-being, more energy, more drive and motivation. We're using it to help memory following menopause and also trauma from post-traumatic stress disorder. And then overall symptoms of anxiety. You can't be anxious and do the IM program. It's impossible. And then we're seeing cognitive changes as well. Improved ability to remain focused, spontaneous speech and communication, understanding things, word retrieval, following step-by-step directions, and of course, managing time, which is crucial. Because of the nature of the IM program, we do see time management improve just because of the nature of the program very often, more often than not actually. The brain training program is a very specific program that is individually designed based upon the individual's neuropsychological test results. So whatever problems are found on their test results is what determines how their treatment plan is going to go, and their program is going to be designed for the brain training. And again, this is the only program that's available, and I think we're one of the few people doing it in the country, if not the only, where we're truly addressing frontal lobe symptoms in a very, very specific manner with hands-on materials that we have designed, and again, based upon the neuropsychological testing. So it's an individualized program, but we're also addressing the frontal lobe, which is a very, very difficult area of the brain to change. And so we're working on symptoms of separation, getting stuck in all of the issues that I've mentioned throughout this webinar. But we're also additionally working on memory, and we're seeing great changes on memory as well. It's making a big, big difference on pre and post testing. So pre and post testing with the brain training is showing improvement in frontal and memory processes. Again, the memory is very robust, and the frontal area of the brain is a harder area to change, but we are seeing some differences. Again, we see a difference with visual spatial, visual perceptual, visual motor. That comes almost automatically with the IM training. So we're getting great results, and it's really helping individuals to work through the aging process, and especially if they've been diagnosed with dementia, to gracefully age through time. In other words, diagnosis of dementia does not mean that individuals can't age gracefully. And these are just a few slides that I've included in this webinar to tell you about our brain training program. This is a slide showing the differences from the brain training, and then this lady began CPAP, which is continuous positive airway pressure for diagnosed sleep apnea. And then the orange is the gain from the brain training program beyond that of the CPAP. So it tells you two things. One, that if used effectively, the CPAP can be very, very helpful to the brain. And two, our impact of our brain training program that even went beyond that. And again, those are the rather robust changes that we're getting in the brain training program as a result of what we're doing in a specifically tailored program. So by the time the day was done with the brain training program, this woman had an above average score. When she started with this score, it was well below average on a memory test. This is the same woman. This was a visual memory. The other one I just showed you was verbal memory. And again, you see where the CPAP actually didn't make much of a difference in the visual memory, but the brain training made quite a robust difference. And this woman went from below average score to a high average score on this particular measure. Again, what are our treatment options? Good sleep hygiene, good mental hygiene, good physical hygiene, as I indicated, mind, body, and spirit. Recommended sleep habits. These are recommended sleep habits by the American Academy of Sleep Medicine. And again, each individual is different. Some people can exercise before bedtime, some people can't. Some people can use caffeine, but these are generally a recommended sleep habits that has been given. I think the most important thing for the aged is to take a walk at dusk if they want to stay up later. That is a very, very important key. The other recommended habit is to keep the sleep environment totally dark, to have no light coming into the sleep environment. And what I would suggest that we have found clinically is not to use some of these noise things or these machines, but actually a CD player with the same music the person's comfortable with over and over, not the radio, not the TV. I also need to caution you on naps. If you take a nap that is longer than 30 minutes, you will risk insomnia because you change your sleep habits. So it's very, very important not to do that. And again, as I indicated, increase the light during the day, afternoon, and early evening, but have no light at night when sleeping. And that light exposure was very helpful with Alzheimer's patients. What are the secrets to graceful aging? Reduce the stress, let things go, walk instead of drive. Do the things will work out, share lots of love and happiness daily, and again, that's social and group activity and participation. More secrets. Eat healthy. Cognitive therapy. Use your brain every day. Treat every day as the most important day of your life. Give thanks. See yourself as part of something more higher than you as an individual. So I hope you've enjoyed this webinar. This is Dr. Fisher, is United Psychological Services, a multidisciplinary clinic committed to providing testing, diagnosis, and support to individuals dealing with a number of psychological and neuropsychological disorders, emotional as well as brain-based, all in one location. Unequaled, comprehensive testing, precise, accurate diagnosis, sensible, successful treatment. At UPS in today's world, we can diagnose early, we can prevent more decline, we can train the brain and improve functioning. Everyone has the ability to age gracefully. Thank you very much. I hope you've enjoyed today's webinar. We appreciate any comments that you have or any questions. Please feel free to call. We also have a website, www.unitedpsychologicalservices.com, and I have a blog that's listed on there as well. And you can email me any questions that you have. Thank you so much for participating. Have a great day.